postgraduate qualification in internal medicine from Royal College of Physicians in the year 2000, Physician Ireland, MRCP, in the year of 2015. He subsequently underwent subspecialty training in respiratory medicine in Malaysia and Australia with special focus on severe asthma using biologics and pulmonary arterial hypertension, PAH. He is currently a pulmonologist based in Serdang Hospital, pioneering in setting up severe asthma clinic and pulmonary arterial hypertension services. He also chairs the Malaysian Thoracic Society PAH Special Interest Group, as well as members of various severe asthma working groups. Without further ado, let's welcome Dr. Lee.
Hi, very good afternoon, and thank you, Dr. Priscilla, for your very kind introduction. I thought I can make it shorter. Right, thank you so much for this Academy of Medicine Malaysia for inviting me to chair these sessions. I'm going to keep it short. As we all know, that severe asthma in Malaysia is having a lot of unmet need when it comes to the diagnosis of severe asthma. I think we're missing out a lot of these group patients in primary care or even in tertiary hospital, and management of severe asthma is not always straightforward. So therefore, we are very fortunate today to have our very esteemed speaker, Dr. Nick Nur Atika, going to give us, enlighten us with a topic on the diagnostic challenges and management of severe asthma. And Dr. Atika is no stranger to our respiratory fraternity. She's graduated from the USM in the year 2008 and completed her master's in internal medicine in UKM in 2017. Then she subsequently underwent the subspecialty training in respiratory medicine in Malaysia, and she's currently the respiratory physician in UK MMC. She is also a very active member in Malaysian Thoracic Society, European Respiratory Society, APSR, ATS, and MABIP since 2019. And her main clinical and research interest is interstitial lung disease and airways diseases. Therefore, she is the best person to talk to us about severe asthma. And let's welcome Dr. Atika, and the floor is yours.
Thank you, Dr. Lee, for your very kind introductions. We meet again here. Thank you, our organizing committee, for handling this the weekly respiratory talk. So I'm Atika, based in UKM. So we will just share a knowledge a bit about and how we will approach in these kind of patients. So I was given a talk of severe asthma, which is diagnostic and challenges, and in terms of diagnostic and also management. Right? So I will actually, these are two-way communications. You can actually ask the questions also, either me or either Dr. Lee also. We are the same fraternity. So let's talk. We actually give you a case scenario a bit, and then we go through the case, and then we look at what we need to know and what actually we need to actually progress in terms of how do you approach a kind of patients like this, and when to refer to a tertiary center or people that we need to get more in terms of management and also in terms of investigations. Okay, so these are the outlines of my presentations. And of course, like what Dr. Lee said before, we have a lot of patients with asthma, whether patient is under follow-up or whether patient is actually taking only medications. So, but we know that asthma can actually sometimes control, sometimes can become uncontrolled. So what kind of patients that you need to tackle, that you need to give urgent medications, or patient that you need to have a lot more investigations on that, right? So in terms of severe asthma, why this is important? Because when you have a severe asthma, of course, the symptoms is uncontrolled, and yet the patients need the hospital admissions. And of course, if the patient is in the hospital and recurrent admissions, it can lead to various of infections and lead to death, right? And of course, when you have uncontrolled asthma, you need acute medications, which is oral corticosteroid. And these medications, you know already, these patients might have a lot of side effects, and it's associated with morbidity. And one more thing is that when you have an attack in terms of asthma, it impacts your quality of life and also impact in terms of work, absenteeism, and of course, you're emotionally unstable, which is psychological well-being, right? And let's see the case first. And from that case, we can go through how we would approach this kind of patients. Either we are a physicians or general practitioners, or whether these are actually a medical officer, right? Okay, this is a 14-year-old boy where it was referred to your center for poorly controlled bronchial asthma. So he had 5 times exacerbations, which require her 3 times intubations for the last year. And as we all know here, right, we see the medications already optimized, where you have a long-acting bronchodilator, you have a long-acting muscarinic antagonist, and also you have a inhaled corticosteroid. This is a triple therapy, which he was on Symbicort, 2-puff PT, Spiriva is a tiotropium, which is LAMA, and Montelukast is leukotriene receptor antagonist, which is LTRA. And on top of that, he had an additional prednisolone, which is 30 milligram OD. So this one is additional. So you see, that means he is not in a good control. By the way, you see, further history, he smokes. Some more, is still smoking. He is also vaping. And he had the other risk factor, which is allergic rhinitis. And he missed a lot of his inhalers, not very compliant. And he had gained weight because of the occasionally getting a steroids. On clinically, he is obese with a BMI of 30 kilogram per meter square. And when you assess the technique, it is very poor. So how would you approach this kind of patients? We always see this case, of, whether in the clinic or whether in the hospital, this kind of patients, right? So let's see. Now, what is these definitions? This patient is uncontrolled. Yes, because he had a poor symptoms control, which is he had a frequent exacerbation. You see 5 times exacerbations, right? This is already more than 2 times per year, plus steroids on treatment, steroid on board. So this is called uncontrolled asthma. Or if we have 1 time per year, which need you to be hospitalized. So this is considered uncontrolled. So these patients, of course, no doubt, this is uncontrolled asthma, right? But what about the difficult to treat asthma? Is this patient is difficult to treat asthma or this is not? So you see here, our patient already had step 4 to step 5 GINA. I will go through this step, the GINA classifications. This is our guideline, base guideline. But you see, there are a few modifiable factors that which is not optimized. Number 1, incorrect inhaler technique, just like what our patients have. Poor adherence, he is not compliant to the medications. And there are a few comorbidities that you need to optimize, right? And this patient is categorized under severe asthma. So what is severe asthma? Severe asthma is actually the subset of difficult to treat asthma, but your all modifiable factors, which is the allergic rhinitis, the obesity, the things, the vaping, the smoking, already in optimized therapy. So if it's controlled, if the symptoms is still uncontrolled, despite of you actually optimize all the modifiable risk factor, so this is classified as severe asthma. These are the GINA classifications of management of the patients, and we have a step 1, step 2, step 3, step 4, step 5. So as I mentioned before, our patient is already in step 5. You see here, we already on LAMA, we already on ICS formoterol, ICS LABA, and he is already on low dose of steroids and leukotriene, LTRA. Okay, so let's see. This patient is difficult to treat asthma. So if it's difficult to treat asthma, then you see the factors, look at the contributing factors, right? As I mentioned before, our patient had the contributing factors that made the patient's the symptoms of asthma is uncontrolled. Number 1, incorrect inhaler technique. Number 2, the comorbidities that he had, which is obesity. You need to know whether this obesity, whether this patient had OSA or not. and the environmental exposure, such as vaping, such as smoking, right? And some of them had no medication side effects, or some of them is actually concomitant with anxiety disorder. So these all must be classified. You see here? And if this all optimized already, like this, you see, we revise the case, you see, this is actually 5 times exacerbations, already on step 5 therapy, but he smokes. So these are the modifiable risk factor, right? Smoke, vaping, allergic rhinitis, and he often missed his inhaler, which is compliance or adherence, and the technique is poor. So we as a physician need to optimize all of these first before we tell that this might be a severe asthma. But bear in mind, we also have a few clues already. Maybe this is classified under severe asthma. Then we optimize all the modifiable risk factors, such as, you see here, smokes. We refer patients to a smoking clinic so that patients will actually quit smoking and vaping. And you can also consider refer to the pharmacist to get the better inhaler technique, or we can actually change the inhaler, right, to get the patients with the proper suitable inhaler for him in a young boy. So what had we done for these patients? You see here, we changed the inhaler, okay? We changed the inhaler to MDI, formoterol, and beclomethasone, and using the aero chamber like this. So that the medications will be very good in terms of inhalations. And because of the patient obese, remember, patient is on steroids and he gaining weight a lot. So he did the polysomnography. What polysomnography? Polysomnography, we want to see whether this patient had the obstructive sleep apnea because of the obesity. So he had the OSA, which is AHI is 15. If it's more than 5, it's considered as positive. So this is actually moderate, in a mild to moderate OSA. So what is the treatment of OSA? We give him a CPAP, continuous positive airway pressure, so that the AHI or apneic hypopnea index improve into 1.2. It's improving. So we tackle all the obesity already. And what about the vaping? So vaping and smoking, we refer him to the smoking clinic, quit smoking clinic, and then we use a nicotine patch. So he quit smoking after 3 months. So very good. And because of the rhinosinusitis, there are also a modifiable risk factor that we can actually optimize. So he went to see ENT and he get his nasal spray. So at this moment, after you optimize everything already, unfortunately, he still had the exacerbations, which is 2 times a month, and he required prednisolone about 10 milligram daily. So what is this classified as in terms of asthma? So would you classify this as a severe asthma? So of course, right? At this moment, you would think of severe asthma. So how would you manage this kind of severe asthma? What should we do? Whether we need to refer to a tertiary center or we need to do a few investigations first before we refer, right? So these are the pathway where in a GINA guideline, there are severe, difficult to treat asthma pathway and also severe asthma pathway. So this pathway, when you see a patient like this, we actually investigate further. How to investigate? Number one, need to rule out the other differential diagnosis. Is it true asthma? Yes, but is it concomitant with other things, such as, you think, other diagnoses such as ABPA, which is asthma plus fungal infections, call it allergic bronchopulmonary aspergillosis. So there are a criteria to diagnose this kind of disease. Yeah? Or do you think that this is an eosinophilic disease, which is concomitant with the EGPA? Or you can actually diagnose whether this patient had bronchiectasis on top of we have asthma, right? And of course, this kind of differential diagnosis have a different investigations that you need to further take and further investigate. Okay. In terms of complications, of course, the patient is on maintenance corticosteroid, so you need to see complications, especially in terms of drug-induced psychosis, which is steroid-induced psychosis. Okay, and also concomitant disease such as pulmonary hypertension or cardiac failure, maybe masking in terms of exacerbations. So we need to rule out all these differential diagnoses by taking a few investigations, such as we take a eosinophil count in a full blood count. We take serum IgE level, which is total IgE, or maybe specific to the IgE that causes the aspergillosis. And we can actually do a skin prick test. You see here, all these investigations, it depends on the physicians, whether this is actually needed or this is actually an additional. Okay. So if you think that all of these differential diagnoses is actually excluded, so you need to know whether these patients is, of course, this is severe asthma. Then if it's severe asthma, we have two types of severe asthma now, which is it's a T2 or type 2 inflammations or type 2 asthma, or with non-type 2 asthma. What is the difference between these two? So this type 2 asthma is actually, it's either allergic driven or it's actually eosinophilic driven. And if it's non-type 2, of course, this is not type 2, means not allergic, means the other related, such as obesity, smoking related, or neutrophilic. Yeah? Why this is important? Because the treatment is actually based on the phenotypes of asthma. Okay, so you can see here, if the patient is actually type 2 inflammations, so these are the important investigations that we need to proceed. Yeah? When we refer to a tertiary center, these are the important things. Number one is blood eosinophils. Number two, if we have a pheno is fraction exhale nitric oxide. So these are the machine where we actually exhale and they actually calculate the nitric oxide inside the, and it's suggestive of inflammations. Okay, if it's more than 20, you see. Sputum eosinophils, I think in Malaysia we didn't do this. And if this is actually can be negative in those patients with steroids. So this must be taken when the patient is actually in the lowest dose of steroids, or maybe can off the steroids and then we'll take. Okay. So this is the type 2 inflammations. Why type 2 important? I think I mentioned to you because in the inflammatory cascade or pathobiological of asthma cascade, you have a lot of biomarkers. When the asthma happen, so you have a lot of biomarkers, such as here you see the interleukin 33, interleukin 25, interleukin 9. So these are actually targeted therapy where the medications is actually target into specific interleukin so that you actually damaging the interleukin and make it actually control. Okay. So let's see first the non-type 2 asthma, how to manage it first. If it's non-type 2 means it's not considered as allergic or it's not considered as eosinophilic. So when this is non-type 2 inflammation or non-type 2 asthma, so you need to have a lot of review again whether this is true asthma, review again whether there are actually concomitant disease such as bronchiectasis. You do again the sputum. You can see again the chest and the HRCT or the CT scan. You can do a bronchoscopy to see why this patient is still coughing or still symptoms despite of giving a treatment. And at the moment, if the patient's already on step 5 therapy, but it's still symptomatic, then but you investigate everything already, which is it's non-type 2, then you have to consider additional therapy, which is maybe you can add on the low-dose azithromycin. We have done here, a lot of patients is on azithromycin. We heard that always, COPD is always the last resort would be the azithromycin to add on. And asthma also have the the benefit of adding azithromycin. Like in the AZISAS trial and also AMAZE trial, we add on the azithromycin, and of course it will reduce the exacerbations. The aim of our treatment would be reduce the exacerbations of asthma, and of course reduce the oral corticosteroid use. And another options would be anti-TSLP. This one is actually will come to Malaysia, I think sooner, but this is also in a type 2 also treatment. I will inform you later. Okay. In terms of other options would be bronchial thermoplasty, whereby you consider giving a thermal to a specific area, where this is actually to reduce the exacerbation and inflammations. But nowadays, I think in this year, we don't have any offer any service for this bronchial thermoplasty anymore. Before this is actually Dr. Lee have done this one in the Serdang Hospital. Okay, so this is the basic approach on the non-type 2 airway inflammations. Let's see those patients with type 2 inflammations. Okay, you know already type 2 inflammations, you need to have these investigations. You need to classify whether this is actually eosinophilic or this is actually allergen-driven. Allergen-driven means you take a total IgE level. That total IgE level can actually be high. So this is allergic component. And if it's you do a pheno also will be more than 20. So this is considered as type 2 inflammations. And another one would be the eosinophil level. Okay, we'll go through this our patients later on so that we can actually understand a bit. Okay, so how we're gonna go on asthma phenotype type 2 asthma. Okay, so these are when we already had the investigations that I mentioned before, that eosinophil, IgE level, and also pheno. Then from there, you can actually choose a biologics. Thank God we have a lot of biologics here and options. We have 4 types of biologics in Malaysia nowadays. Before that, when I was as a physician, we only have one, which is anti-IgE, which is omalizumab. So all of these, you need to start based on the number 1 is eligibility, number 2 is your accessibility, and number 3 is of course the cost, and number 4 is based on your patient's bioprofile. So as these patients, you see here, the options would be, we have anti-IgE, we have anti-IL-5 or anti-IL-5R, or we have anti-IL-4R and anti-TSLP. These are all biologics for asthma. Yeah? So based on this, anti-IgE, usually we use in the allergic-driven. Those patients with IgE level very high, so these are the options. If the patients had an eosinophil high, so the options would be anti-IL-5 or anti-IL-5R. Yeah? Or if the patient is already on steroid, maintenance steroids, and also pheno high, so we will choose anti-IL-4R, but depending on the availability. Yeah, and these are the predictors of the asthma response. So those patients with higher eosinophil, higher IgE level, or higher allergen-driven will actually very good response to these biologics. And for those patients had nasal polyposis, or patients had a higher eosinophil level, this is actually a good options. And we see here, if it's higher pheno, the dupilumab is actually a good response. Okay, let's see a bit. These are these are important for fellows, especially for us to remember. So this is anti-IgE. So the example of anti-IgE is omalizumab. So what omalizumab do is actually in a patients of subtypes of allergic. Yeah. So what this omalizumab, why this omalizumab is the best is because it can actually reduce the exacerbations and quality of life in allergic patients. Yeah. So these are proven by a few study, which is Tel-Air and Prospero study. So all of these biologics is actually improved in terms of quality of life and also improved in terms of hospitalizations. And anti-IL-5, we have mepolizumab, but this is actually in IV preparations. This all is actually subcute preparations, subcute subcute Benra. So we have benralizumab, where the study Sirocco and Kalima showed that the exacerbations and quality of life is actually improved by 55%. And those patients that benefit in benralizumab will be those patients with eosinophilic and also nasal polyposis. For MEPO, we always use it with the patients with EGPA. So these are actually meant for then the EGPA patients. And another options would be dupilumab. So Liberty and Venture study have shown that the exacerbations and exacerbations is reduced by 59%. And it is actually good in patients with higher eosinophil and also higher FeNO. And the other that will come soon in Malaysia is tezepelumab, which is TSLP. So these are targeting the whole things, which is those patients with non-type 2 asthma and also type 2 asthma. So if these come to Malaysia, the other medications would be a bit compete to these medications. Yeah. So these are the preparations. You see, anti-IgE or omalizumab subcute. Yeah. So this was given based on the body weight and also given based on IgE level. And you see here the cost, it's about 1 kF per vial. So the patients most likely need 2 vials every 2 weeks. So the cost would be about 3,000 to 4,000. Yeah? And in terms of anti-IL-5, you see anti-IL-5R, Benra, we only need, it's not weight dependent. So only 30 milligrams subcute, and it was given once in 4 weeks for 3 doses, and then every 2 months. Yeah? So these are the costs, and these are the other options would be dupilumab, it's subcute. For first dose would be 600 milligram injections, 2 injections, and subsequently it depends whether you need a 200 or you need a 300 milligram. And this tezepelumab also, this is only one subcute 210, it's every month. Yeah? So these are the pathobiology of type 2 asthma, where I mentioned before. This is actually in terms of the targeting the biomarkers. You see here, the omalizumab is targeting the IgE. Dupi is IL-4 and IL-13R. IL-13, sorry. And here is the MEPO or Benra is IL-5. Okay. So when you start to use the biologics, pilih salah satu, we choose one, and then you will see a response. Okay. What response you need to see? Number 1, in terms of asthma symptoms. Number 2 is your ACT score. And number 3, your side effects of the medications. And of course, the number 4, whether this patient is actually suitable for the medications, right? So you reevaluate at least here, you see, choose one, trial of 4 months. You try 4 months first, then you assess the response. If it's good response, then you keep the biologics. You maintain, you monitor according to what each biologics needed, which is every 2 weeks, every 4 weeks. Right? Then you maintain the treatment of inhaled corticosteroid, or we can actually try to reduce the inhaled corticosteroid at least to the moderate dose. But the first thing we need to do is actually to decrease the oral corticosteroid first. When the patient is on maintenance, you have a response, very good response. Try to reduce the steroid slowly and taper it off. And you reevaluate after 12 months whether the biologics needed or needed to be continued or can stop. Okay. What to review is here, asthma symptoms, the comorbidities and the treatment, and of course the patient satisfactions. If After 4 months, you assess it's no response, which is patient still exacerbate, still need admission, still ventilated, and this we may consider to switch to a different type 2 targeted therapy if they are eligible, or if it's the patients had other options. Or if it's unclear, you still maintain whether it is responding or not responding, but will still can actually extend up to 12 months to see the response. Sometimes it takes a bit longer. Okay. So what is when you have all the biologics treatment already, settled already, patient is already asymptomatic, control asthma already. So the ATS guideline said that it is include into a clinical remissions. What is clinical remissions? So following 12 months of biologics, the symptoms is actually improved, whereby the ACT score is more than 20, and you don't have any absentees, and you have no exacerbations, and you're not on any OCS, and you only have low or medium dose of ICS, LABA or ICS, and only use one SABA usage sahaja. So that means this patient is in a clinical remissions. Okay. So just look back to our patients. You see, a 14-year-old boy just now, 5 times exacerbations. Of course, this one we know already. This is in a classifications of difficult to treat asthma, right? After we actually optimize the modifiable risk factor, we did something already. Then it's still exacerbate. So this considered as severe asthma. Okay, so this severe asthma, so we know already we need some investigation, which is eosinophil count, we need the serum IgE level, and we need a pheno. We do a HRCT and spirometry. Of course, this one you see, eosinophil count 2.0 means 200. 15.0 means 1,500. So 200 to 150,000. It's more than 150, then it's considered eosinophilic. Okay. Serum IgE level, the normal IgE level would be 100, but this one is 1,800 to 3,300. So that means this is allergic driven, right? The pheno is actually borderline. So it's more than 20. If it's more than 20, then it's high. So this is borderline, about 25 parts per billion. Okay. HRCT, there's no other features to suggest the other differential diagnosis. Okay. And spirometry, of course, because patients are obese right now. So that's why it comes out to be restrictive ventilatory defect. Despite of sepatutnya, this patient had obstructive ventilatory defect, right? With negative reversibility, because why? Patient is on steroid and patient is still on medications, MDI, most probably. And patient is actually obese. So what is the options? How we choose the biologics? We can see now, right? Which one would we choose at this moment? So, however, there's no head-to-head comparison between one-to-one biologics, but depending on the bio profile. You see, bio profile, IgE level high. Yes, I would choose the one first, which is anti-IgE, right? Omalizumab. And the comorbidities or OCS dependent. I can also choose benralizumab, right? Because eosinophil level is high also. And I also can choose the dupilumab, which is IL-4, which is patients already on corticosteroids therapy, but the pheno is not that high, right? And it depends on the availability of the medications and also the cost. So what this patient have? So because this patient is allergic driven, IgE is high, so eosinophil is high, OCS also dependent, so we choose omalizumab. But remember, omalizumab is dose dependent on weight and also IgE level. Let's see after this. These are the latest New England Journal of Medicine, which actually give us the approach on how we would choose the biologics. This one of the considering factors, such as you see, when patient is in severe asthma, whether you have a oral corticosteroid dependent or non-corticosteroid dependent. If it's steroid dependent, then you see the eosinophil level. Eosinophil high, then these are the options. These are actually good diagram, the pathway to see, right? but it depends on the availability. And if you see here, our patients, looks here, our patients, so it is in 150 to 105,000, 1,500, sorry, and the biomarkers would be here. The options would be anti-IgE, or can be anti-IL-4, or it can be anti-IL-5, or basically the whole set of biologics you can actually use. But remember, I mentioned before, I choose omalizumab. However, in omalizumab, you see here, it depends on body weight, and also it depends on IgE level. So IgE is very high for this patient, which is 1,500. So almost 600. Yeah. And according to the weight also, it's here, 600 every 2 weeks. So this one, 600, you need 4 injections. 1, 2, patok 2. So 4 injections at 14-year-old boy. So this may consider you. So the other options would be subcutaneous benralizumab for 30 milligram every month, right? So I've come into the end of my presentations already. So hopefully you get something benefit here. So these are the take-home messages. Of course, the severe asthma will come have poorer outcomes and major impact to our quality of life and psychosocial. That's why we need to tackle it before it's become uncontrolled. And it is actually a subset of difficult to treat asthma, whereby the control is actually already optimized the therapy plus the modifiable risk factor. And there are 2 types of phenotypes of asthma. We have type 2 inflammations and we have non-type 2 inflammations. So based on the type 2 inflammations, there are biologics to be chosen, but this is based on the clinical bioprofile and also biomarkers. And we have 4 types of biologics in Malaysia, except anti-TSLP yet. We have anti-IgE, we have anti-IL-5R, anti-IL-4R. Yeah? So if we start a biologics, of course, we need to monitor at least 4 months treatment, and we are assess whether this is good response. And clinical remissions is defined as if we are in a biologics for 12 months, no symptoms, no OCS. So this is actually clinical remissions. Okay, with that, I thank you. It's early. I'm sorry.
All right. Thank you so much, Dr. Atika, for a very enlightening talk on severe asthma. I'm sure our audience have gained a lot of new knowledge today. I always like to have discussions, around one case, during the presentations. Very well done. All right. Can we have a look if there's any question at all? All right. Yep, as usual, our Malaysian are quite shy to ask questions. As just a reminder, you can just click on the Q&A. Oh yeah, I can have one question
I can
here.
ask.
Yeah,
No, we're still doing a thermoplasty, Dr. Lee. Sorry, I'm not doing thermoplasty, but Dr. Lee is actually in interventional hospital. So do we still do a thermoplasty now?
Yeah, very good questions. There's a lot of problem coming up. The short answer is we have not been doing a bronchothermoplasty for quite a while already. At least I think for the past 4 or 5 years, we have not done any. I think this is partly because of the available biologics now in our country is quite. I mean, it's better than the last time. So I think many patients who have tried on one of the biologics that prevent them from doing BT bronchothermoplasty. The second reason is I think the manufacturer may not be very interested to continue to manufacture the catheter for the bronchothermoplasty now from the company. So the short answer is actually no, not really. It's been a while since our last one.
Okay.
So yeah, maybe let me just ask first few questions first before we going through our audience questions. So as we all know that the cost of biologics is extremely high based on your table that you have. So how do you overcome this at your center? How do you prescribe, any way that you can get funding, or what's your tricks, of starting your patients on biologics?
Yeah, this one is especially in the MOE status. So we actually have a lot of issues in this kind of in actually treating asthma patients, severe especially in terms of biologics. So one of the I think the pitfall is actually the patients need to pay by themselves, number one. Number two, in terms of funding, we can get a funding if the patient is actually a government servant. So government, we try to get from JPA, and most of our patients is actually approved. The applications is approved. So it's very good. The second funding that we have is actually Tabung Kebajikan, our JKSP, Jabatan Kebajikan Sosial Perubatan. So they will actually actively manage. So they will come to a conclusion. Sometimes they give one month supply, and sometimes they give only 2 months supply, depending on the case, depending on the financials of the patients. And I have one patient is under KWSP. KWSP also very good in terms of this service, giving a lot of, a good outcome. So KWSP can give a financial support until 1 year, very good. And another one is Ma'ik and Zakat. So they all also give a lot of good response to us so far. So we have, I think, 10 of them is under 2 under KWSP, 1 under insurance, and others is under government. So so far it's good in terms of response.
Yeah,
But
I think the funding is the very real issues that we are facing in the government hospital, you know. So that's
yes,
why I think I ask these questions, and hopefully there's anyone from the higher authorities listening to our talk, okay,
yeah.
about this the unmet need. You can see that all the source of the source of funding are actually not from the government. They are all from other sources but the government. So I think this is something very sad here.
True.
So I hope that whoever is listening here who is from the government side, please kindly look into that. But we are working up something to hopefully can get extra budget. You know, I think Dr. Azhar has been very active in pushing it through. I think to ask you the second questions, I think is relevant to the question that asked by one of the audience as well. I think just very recently, we are coming out with the idea of clinical remission. So I'm very happy that you touched on that topic as well, because all around the world, everyone is trying to find asthma clinical remission in a different way. And fortunately, you picked the American one because they are the one with the longest criteria to define a clinical remissions. So my question is, how do you see this idea of clinical remissions in our clinical practice? I think this is so relevant to Dr. Noor Eliana questions. I think about stopping the biologics if already achieved clinical remissions. How do you see this is going to help us, you know, in deciding our direction of care?
At this moment, we don't have anyone that have a clinical remissions yet so far. But so far, we attended a lot of patients. I have 2 patients actually. We actually try to stop a biologics after 2 years. She was on benralizumab for 2 years already, and suddenly we stopped. After 1 year, she came again with the exacerbations again, and we tried to get another one funding again for these patients for the same biologics. But after we start the same biologics, it turns out to be not improving. So it's a bit difficult to say what in terms of clinical remissions so far. So as far as I'm concerned, in the APSR just lately, they also mentioned about the clinical remissions. They have a lot of criteria to define the clinical remissions. Are they in 12 months? Are they actually extend more than that? So at this moment, in terms of relevance of the clinical, the clinical remission so far, in Malaysia, in my center is actually, so far, I didn't see any one of them is actually in a clinical remissions after we start the biologics. In a good response, it's a good response, but remissions per se is actually, it's still not properly addressed on that, I think. So or anything that Dr. Lee come across in your practice for this.
Right. Yeah, well, see, I think we are trying to have, not just me, I think the rest of the senior respiratory physician in Malaysia, they're trying to possibly will be included in the next CPG, I hope so. To talk about these clinical remissions in Malaysia, because I think many countries try to define different way, and it has to be catered to local setting, because there's a lot of things that we don't have, just like overseas, that American one, because there are a lot of insurance things that they have to think about. So the clinical remissions idea has to be very strict. So when coming back to clinical remissions, it's just essentially what you were saying, when patients are well enough, essentially they are just almost close to like a normal person. But in my view is that if you label a patient in clinical remissions, what's next? That's the most important question. Is, do we stop biologics? Do we have enough evidence? Well, yes, some biologics can be stopped, but in my personal experience, possibly it seems like yours, they actually come back with exacerbation, depending on how long. Some came back in 6 months, some came back in 1-2 years time. There are some very lucky patients that they do not have any exacerbation. I have not seen this kind of patient in Malaysia yet, but majority of them is possibly due to some allergic triggering which been removed from their life, which happen to be, moved to a new location, and then biologics works in certain way, and then therefore they are completely fine, from exacerbations. But otherwise, I agree with you, clinical practice is so hard to find one true clinical remissions. If even the fact that we're trying to define it, but whether are we going to find them is still a big question mark. So I think they will leave it up to our CPG working group to see how we're going to define these clinical remissions.
So maybe they conclude the data later on those patients we stop the biologic. I think Dr. Azhar have a lot of data when they stop the biologics, and how many years they come back again with the symptoms. So maybe we can have other definitions for that later.
Yeah, great. So well, we do have another questions asked by Dr. Azhar. Well, even though it may not be too relevant to your topic, because his question is more to exacerbation. So yeah, about the role of IV medicines out there. I'm not sure if you would like to take that questions.
Okay, for the exacerbations, I think the guideline have mentioned that once IV Maxaf only once, and then if it's not, then you need to intubate right nowadays. So, and not only IV Maxaf is actually one of the treatment. The other treatment would be, you need to consider also, which is the systemic corticosteroids on board, the inhale nebulizer, and in terms of starting the inhale corticosteroid at that moment also, right?
Yep, totally agree with you. Yep, the short answer is there's some evidence on that. Many guidelines have suggested that, not just Malaysia. But for second dose, not quite sure. I believe you do not want to wait until patient really dying in front of you. Yep. So do we have any other questions here? We still have about 5 minutes to go.
Topic very difficult, I think, because the biologics is actually not that common in other center and practitioners, right?
Yeah.
Maybe they can actually refer to us when they suspect that this is actually going to be a severe later on.
Yeah. So I think there's something to share is that we are trying to work up with some severe asthma network to link the primary care and some tertiary hospital with no respiratory physician to the nearest severe asthma clinic. So we are working on that. Hopefully one day we will roll it out, even though we have rolled this out for quite a while, where you can log on to a Malaysian Thoracic Society. There's a severe asthma referral forms, which I also have the privilege of participated in creating the forms. So you can download the forms and actually refer to the nearest severe asthma clinic. Otherwise, we have started some pilot project. I think the northern side in Alostar, they have started pilot project, as well as Kelantan, they have started pilot project with some identified primary care to take
True.
in this group of patients because we are missing a lot of this group of patients.
Yes.
Yeah.
They have the link, Google link, I think. They just click the link and then they put the name, everything, and referral. So they can actually assess. We can actually advise them what to do. Yeah.
Yeah.
This one is great, actually. We need to do. But in a Klang Valley, it's very big. But maybe one MTS can actually do that and then be a center of that, right?
Yeah. All right. I think we have maybe 5 minutes. Let me ask the one last question. Do you have any, Dr. Tika, do you have any patients that you managed to stop inhaler? Or do you ever stop inhaler for patients on biologics?
So far, no, except the steroids only. I managed only to have a low dose of steroids on board, but the low dose of ICS sahaja, inhaled corticosteroid on board, but never stop the steroid. No, never stop the ICS. I don't know whether your center have also.
Yeah, well, that's a very good thing, well, yes, the short answer is I do have one, but it's
Wow.
not me because I don't stop. As you know, the majority of us, we do not want to stop inhalers, even I'll give them the lowest dose possible, as a maintenance. I don't
Yeah.
normally stop inhale corticosteroid, despite the fact that we all know that on biologics is one thing, but inhaled corticosteroid is one thing. But I do have one patient who self-stopped after biologics. He felt so well that I stopped it, and then he hid it from us. We didn't know until one day that when they asked, how's your inhaler? Then he mentioned, oh, I stopped using it for months. So this is the amazing thing of biologics. It's true. It's true. It can change somebody's life. That's why I think we need to focus on severe asthma.
Yeah.
All right.
Mm.
Any more?
Hopefully our CPG come one day, and then this one is actually included there. We also have nowadays we have a lot of severe asthma conference, so that we can actually update and upgrade ourselves.
Yeah, sure. So if there are no more questions, I think we can close these sessions and pass it back to Dr. Priscilla from Academy of Medicine Malaysia.
Okay.
Okay. Thank you, Dr. Atika and Dr. Lee, for the wonderful talk. Very enlightening to hear this severe asthma talk, which is eye-opener for general physician like us. Okay.